Yep.
Okay. Perfect. So hi everybody, welcome to your MedSoc tutorial on renal medicine. I'm Sumayyah, one of the 5th years, and I'll be doing the first part of your tutorial, and then Ameerah and Shazmen, who are also 5th years, will be doing the remaining parts. So just a reminder that these tutorials are not exhaustive on everything you need to know, but they do contain the high-yield facts, and so will be a good guide to the type of stuff you'll need to know for your AKTs and CPSAs. How long have I been muted?
Just a few seconds.
Okay. Chronic kidney, renal replacement therapy, UTIs, polycystic kidney disease, nephrotic syndrome, and then glomerulonephritis. So before we learn about diseases that affect the kidney, it's just quickly important to understand the function of the kidney. So your kidneys are obviously two retroperitoneal structures that lie either side of your midline between T12 and L3 vertebrae. The inner kidney consists of the medulla and the cortex, and then the cortex is composed of the outer cortical zone and then the inner juxtamedullary zone, as well as the renal columns that separate the renal pyramids. The cortex is what holds the nephrons, and these are the functional units of the kidney, which is where ultrafiltration takes place. And then the medulla consists of around 10 to 18 renal pyramids. And then once filtration has happened, the urine collects in the renal pelvis, which goes into the ureter and then empties to the bladder and then is excreted. So in terms of the function, the main function of the kidney is to filter our blood and regulate our body fluid volume. So the kidney can detect if our blood pressure is low or high, and then via the renin-angiotensin aldosterone system can adjust it accordingly to ensure adequate blood pressures. It's also involved in acid-base balance, so by excreting H+ ions and making carbonate ions, the kidney can control the pH of the blood. It's also involved in excretion of waste products and toxins. So blood contains waste products. One is urea, which is from the breakdown of proteins, and the buildup of urea is toxic to the body. So the kidneys filter out the urea and then the excess water and ions and then excrete it in form of urine. The kidney also has a hormonal role. So the first one is erythropoietin, or EPO. So EPO is produced in the renal institution and it's secreted in response to cellular hypoxia. So it acts on the erythroid precursors to make new red blood cells. It's also involved in the synthesis of renin. So renin is released by the juxtaglomerular apparatus cells of the kidney in response to reduced renal perfusion and low sodium delivery to the distal part of the renal tubule, and then acts via angiotensinogen in the lungs and ACE to increase water reabsorption. And then vitamin D. So vitamin D is metabolism important in so just a quick note,
Hi, I think your voice has been muted again, or I can't hear anything.
Sorry, just a second. We're just sorting it out now.
Am I back?
Yes.
Yep.
Yes.
Yep.
Okay, sorry. Can you guys still see my screen?
Yep. Yep.
Okay, perfect. So sorry about that. I was just saying that urea is a waste product that is produced by the liver and excreted by the kidneys. Creatinine is a breakdown product from muscles and it's excreted by the kidneys. Both are raised in kidney injury because the kidney is not doing its job correctly in terms of functioning, in terms of filtering these out. There are other factors that also affect the urea and creatinine levels. So for example, urea can be increased if there's dehydration, if there's a GI bleed. That's quite a good marker that somebody is having a GI bleed if their urea is high. If there's high protein breakdown, for example, in trauma, in infection or malignancy, or high protein intake. Urea can be decreased if the patient has liver disease or has malnutrition or is pregnant. And then the creatinine can also be raised if there's a high muscle mass, if the patient has undergone strenuous exercise, or if the patient has taken trimethoprim, which is an antibiotic. And then low creatinine if there's a low muscle mass as well as pregnancy. Okay. So the first presentation, and probably the most common kidney presentation that you will see, is AKI. Now, AKI is defined as an acute drop in kidney function, and it's diagnosed by measuring the serum creatinine or the urine output. So it occurs in between hours to days, and around 15% of patients admitted to hospital develop an AKI. So in terms of the NICE criteria for an AKI, it requires the patient to have a rise in creatinine of over or equal to 25 micromoles in 48 hours, a rise in creatinine of more than or equal to 50% in 7 days, or a urine output of less than 0.5 milliliters per kilogram per hour for more than 6 hours. Now, an AKI is staged according to the KDIGO criteria. So as you can see from here, stage 1 AKI would mean if a patient's creatinine has increased between 1.5 to 1.9 times their baseline, or the creatinine has increased by more than or equal to 26 micromoles per liter, or their urine output is less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. Now, these criteria are really important to understand and memorize because you'll get a lot of questions that ask you to identify the stage of AKI a patient is in. Usually, it can suffice for you to kind of memorize one thing. So, for example, if it's the creatinine of all of those, but I would suggest you memorize all of it just in case they ask you to compare something else, another parameter such as urine output. So stage 2 AKI would be a creatinine increase between 2 to 2.9 times the baseline, or urine output of less than 0.5 milliliters per kilogram per hour for more than or equal to 12 hours. And then stage 3 AKI would be a creatinine which is increased 3 times their baseline, a creatinine which is greater than or equal to 354 micromoles per liter, an initiation of dialysis, or a urine output of less than 0.3 milliliters per kilogram per hour for more than or equal to 24 hours, or if the person has been anuric for more than or equal to 12 hours, which means they haven't passed any urine in that time. So the causes of AKI can broadly be categorized into pre-renal, renal, and then post-renal etiologies. And this is a good structure to use if you're in an OSCE. So pre-renal AKIs are due to an inadequate blood supply, which means that there is not enough blood being arriving at the kidney for the kidney to filter it. And some causes include hypovolemia. So for example, if the person has undergone trauma or there's blood loss or severe dehydration. Dehydration is probably the most common one you'll see, especially in older people presenting with an AKI. Another one is heart failure. And then you've got renal vasoconstriction, which decreases the amount of blood reaching the kidney, or systemic vasodilation through sepsis or drugs or hypotension. So the blood is being diverted elsewhere. A renal AKI would be one in which there is an intrinsic defect within the kidney, and this can be separated into something wrong with the glomerular apparatus. So for example, glomerulonephritis, which we'll cover later on today. Something wrong with the tubes. So for example, acute tubular necrosis. Something wrong with the institution. So you've got acute interstitial nephritis, toxins that may affect it, an infection or an infiltration, for example, sarcoidosis. And then something wrong with the vasculature. So for example, if there's vasculitis or scleroderma. And then post-renal causes of an AKI are due to obstruction, which means that there is an obstruction to outflow in the kidney, and therefore the kidney's function is being affected as a result. Now, these can be separated into intramural, which is within the ureter itself, so the inner lining. So, for example, if you've got a stone or a clot. Transmural, which is within the ureter, so the walls of the ureter. For example, if there's a stricture, and this can be congenital or acquired. The surrounding area of the ureter, and that can be due to an abdominal or pelvic mass or tumor, a lymphoma, retroperitoneal fibrosis, or prostatic hypertrophy, which can impede the ureter. Okay, so in terms of the main risk factors for an AKI, they can be remembered with the acronym STOP. So S stands for sepsis and hypoperfusion, which, as we said, cause most of the cases of an AKI. Toxicity, for example, a drug that may be toxic to the kidney. Obstruction, and then P stands for parenchymal kidney disease. And this is in order of most common to least common. So in terms of investigating whether somebody has an AKI, we can do different exams. So for example, at the bedside, we can do a urinalysis. And then if we see leukocytes or nitrites, it might suggest an infection that might be causing an AKI. If we see protein or blood, that might suggest acute nephritis. Or if we see glucose, it might suggest, for example, diabetes. We can also do an ECG at the bedside, and that may indicate complications of an AKI, for example, hyperkalemia. We can also do bloods. So for example, looking at the full blood count, and if we see things like thrombocytopenia or evidence of hemolysis, that may indicate that there are blood cells blocking the kidney. The urea and creatinine is probably the most important test because, as we said, it's how we classify the stage of the AKI, and we'd see elevated, urea, creatinine, etc. Liver function tests, glomerulonephritis screen if the cause is unclear, and then glucose, clotting, calcium, ESR, etc. In terms of imaging, so if we think by this point we haven't found anything wrong with the pre-renal side or the renal side, we might do an ultrasound to see if there's a cause of obstruction. We might also want to consider ECG, as we said. We might do an X-ray to look for signs of heart failure or pulmonary edema. And then we can also do an ABG or a VBG to look for metabolic acidosis, which would be a complication of reduced renal function. Okay, and then these special tests are, like we said, if we still haven't found the cause by this point, we can look for autoantibodies, we can look for paraprotein if we're thinking myeloma, complement levels, etc. Okay, so now in terms of managing an AKI, the management is largely supportive. So first of all, we want to prevent an AKI from occurring. So like we said, a lot of patients who come into hospitals end up having an AKI. So in order to avoid this, we might do things such as avoiding nephrotoxic medications, ensuring that there is an adequate fluid intake with IV, and then investigating and treating any underlying causes the patient might have. So if it is a pre-renal AKI, we want to make sure they're being rehydrated with IV fluids. We also want to stop any nephrotoxic medications, and we'll speak about this in the next slides. If it is a post-renal cause of AKI, we want to relieve the obstruction. So for example, if a patient is in retention from an enlarged prostate, we might want to insert a catheter to drain the urine, and in that case, we'd need a urologist. And then for all patients, we want to monitor them regularly, so frequent monitoring, checking their electrolytes, checking their ABG, checking their lactate to see if they're septic or hypoperfused, their fluid charts, their weight, and then 4-hourly urine outputs. Now, if it's a severe AKI, they may need dialysis, which we'll cover later on today as well. And in this case, we'd need to contact the renal specialists. Okay, so when it comes to real life and exams, we want to make sure that any patient that has a suspected AKI, we need to stop all potential nephrotoxic medications. And these can be remembered with the acronym STOP the DAM drugs, where DAM is the acronym for the medications. So the first one is diuretics, then we have A stands for ACE inhibitors or angiotensin receptor blockers, and then aminoglycoside antibiotics. Metformin is the third one, and then NSAIDs. Now, metformin and a few other drugs such as lithium and digoxin, which we would also stop in this case as well, they don't worsen the AKI itself, but because they're renally excreted, if the kidney is not functioning properly, these will build up and can become toxic. So we need to avoid giving these in patients with an AKI as well. So there's the note here. So this is an image of the glomerulus, which is the ball of capillaries that is at the beginning of the nephron, and it's where ultrafiltration takes place. So we have the afferent arterioles, which bring the blood, and then we have efferent arterioles, which take away the blood. Now, at the afferent arteriole, prostaglandins act to dilate the arteriole, which increases blood flow and therefore would increase filtration. NSAIDs, which is a medication we want to stop, block these prostaglandins and as a result cause arteriolar constriction. This would reduce the glomerular pressure and filtration and therefore worsen an AKI because the kidney is already not functioning well and we're further decreasing blood flow to it. So we don't want to do this, and thus we want to avoid NSAIDs. In terms of the efferent arteriole, angiotensin 2, which is part of the renin-angiotensin-aldosterone system, acts to constrict the arteriole. And this increases the pressure in the glomerulus because the blood here is working against a higher pressure, which increases the filtration at the glomerular capillaries. ACE inhibitors block this angiotensin 2, which causes the efferent arterioles to dilate, which would reduce the pressure and thus filtration. This is why we need to stop both these drugs in an AKI because they reduce the filtration in an already malfunctioning kidney. Now, in your CPSA, you may get a prescribing station where the patient has an AKI, and excellent students would be able to identify whether the patient is on any nephrotoxic medications, and you need to cross this out your prescription. So you need to cross it out the drug chart. Okay. So now, moving on to complications of an AKI, this is quite a high yield topic. So the first complication of an AKI is metabolic acidosis. So as we discussed at the beginning, the kidney excretes H+ ions and can make carbonate ions, bicarbonate ions. If the kidney is not functioning properly, such as in an AKI, less H+ ions are excreted and so can build up in the blood and cause a metabolic acidosis. The second complication, probably the most important one, is hyperkalemia, because if you do not treat the hyperkalemia, the patient can have life-threatening arrhythmias. So in terms of the classification of hyperkalemia, mild hyperkalemia would be potassium or a serum potassium of between 5.5 and 5.9 millimoles per liter. Moderate would be between 6 and 6.4, and then severe would be more than or equal to 6.5. And we want to treat hyperkalemia if the potassium is greater than 6 millimoles per liter with ECG changes, or if the potassium is greater than 6.5 millimoles per liter. So here, this is what I'm talking about. Okay, so in terms of, I'm just going to quickly skip this so you can see the ECG. In terms of ECG changes that you might see in hyperkalemia, you can see peaked or tall tented T waves. You may see a loss of P waves. You may see broader QRS complexes, or in the most severest of cases, you might see sinusoidal waves, which is when you have waves that resemble the sine pattern. So hyperkalemia is an emergency and it needs to be treated ASAP, and you'd follow the ABCD algorithm for this. In terms of managing the hyperkalemia itself, the first step is to always stabilize the cardiac membrane, and we do this via IV calcium gluconate. So this just prevents the potassium from having an effect on the heart and causing severe arrhythmias. The second step is to shift all the extra potassium from the extracellular compartment into the intracellular fluid compartment. And we do this via an an insulin dextrose infusion. So it's usually IV insulin 10 units in 25 grams of glucose, and then we give 250 mils of 10% of this over 5 minutes. We might also consider salbutamol nebulizers because salbutamol causes potassium shift. However, there is a risk of tachycardia with salbutamol, so we need to be careful with this. And then the third step is to actually remove that excess potassium from the body. So calcium resonium is written here, but I remember on my renal placement, the renal consultant said they don't actually ever use calcium resonium because it's kind of like swallowing chalk, which is not too pleasant for the patient. So they use, I think, something called more often in the hospital. We might also consider loop diuretics, and then if there's persistent hyperkalemia, for example, it's more than or equal to 7 millimoles per liter, we would refer the patient for dialysis. The third complication is fluid overload because the kidney is not filtering properly, so the patient might get heart failure or pulmonary edema. And then we have uremia, which is a buildup of urea in the blood, and this can lead to encephalopathy or pericarditis. But the most common symptoms that you'll see in past med or any exam questions are nausea, vomiting, and fatigue as a result of the uremia. Okay, so now I just quickly want to touch on acute tubular necrosis and acute interstitial nephritis. So acute tubular necrosis is an intrinsic cause of an AKI, and it accounts for almost up to half of all AKIs. So ATN is damage and death, so necrosis of the epithelial cells of the renal tubules. It's the most common cause of an AKI. Now, what happens is, because of reduced blood flow to the kidney, there is ischemic or toxic injury to the renal tubular epithelial cells. These begin to die, and then they fall off, and then they can block up the tubes and cause tubular dysfunction. So this can be, this is what happens. You can see here, you've got ischemic insult, and then the cells fall off the sides and then can block the tubes. So there are two main reasons that an ATN occurs. So the first is in ischemic injury, for example, if the patient is in shock or there's sepsis or severe dehydration. And the second one is nephrotoxin. So the most common ones you need to know are aminoglycosides such as gentamicin or amikacin, amphotericin B, NSAIDs, myoglobin secondary to rhabdomyolysis, radiocontrast agents, and then lead or poison. Now, the pathogenomic thing that you will see with ATN in exam questions is something called muddy brown casts, which is what we see in urinalysis. So if ever you see a question where it's referring to muddy brown cast, which is seen in urinalysis, you can be pretty sure that the patient has ATN. Now, in terms of the management of ATN, it's supportive. So we want to give them IV fluids, stop any nephrotoxic medications, and then treat any complication just as we would with AKI. Now, acute interstitial nephritis is a type 4 hypersensitivity reaction where there is an inflammation of the tubules and the interstitium. This accounts for around 25% of drug-induced AKIs. So the most common cause is drugs, and I'm just going to get the whole slide up. The most common cause is drugs, so for example, antibiotics, NSAIDs, allopurinol, mesalazine, phenytoin. If the question stem has reference to any of these and the patient has symptoms of an AKI as well as the three other things that are seen with AIN, you can suspect acute interstitial nephritis. So the way this patient would present is they'd have an AKI. 10% of cases would present with the allergic triad. So for example, fever, rash, and arthralgia. And then we'd also see hypertension. Other causes include infections and then autoimmune causes such as lupus or sarcoid. You would also, in the investigation of an acute interstitial nephritis, in the urinalysis, you might see pus in the urine, which may indicate an infection, or you might also see white cell casts. In a full blood count, and I think this is quite pathogenomic for AIN, is eosinophilia. So you see a high eosinophil count in the patient's blood. And then if you do a biopsy of the patient's kidney, you might also see inflammatory infiltration of the interstitium, and you might also see some edema. In terms of the management, so you want to treat or remove the underlying cause. So for example, if it's a drug, you want to stop it. If it's an infection or an autoimmune cause, you want to treat that. And then you want to give the patient steroids. So you'd give them 40 milligrams of oral prednisolone and then monitor them to see if that improves. Okay, so now onto an SBA then. I'll let you guys read the question. And I'll give you a minute, and then if anyone wants to have a go, please shout out, and then we will go over it. Okay, does anyone want to have a go? Shazmen?
I'm not sure.
Okay, that's fine. We'll go over it. So the question says, a 40-year-old woman has recently been started on 1.25 milligrams of ramipril once daily by her GP for hypertension. She comes back a few days later complaining of shortness of breath, especially when lying down. The GP rechecks her kidney function and the results are below. What should the initial management be? So we've got a patient, her creatinine 6 days ago was 80 and her eGFR was greater than 90. Now today her creatinine has increased to 130 and her eGFR has decreased to 80. What should we do? So the answer is C. And the reason it is C is because ACE inhibitors, because of their mechanism of action, they cause the creatinine to increase because they cause the glomerular pressure to slightly decrease. However, we only allow a rise in creatinine of about 6 up to 30%. So if the patient's creatinine increases more than 30% when they've been started on an ACE inhibitor, that usually means they have an underlying renal disease such as renal artery stenosis, and we don't want to give them an ACE inhibitor. So the answer would be to stop the ramipril because she's had a 60% increase in her creatinine. And then ACE inhibitors would be contraindicated in renovascular disease. So for example, if the patient has atherosclerosis or fibromuscular dysplasia or renal artery stenosis, we wouldn't start them on ACE inhibitors. Okay, so to touch on rhabdomyolysis then, rhabdomyolysis is a condition where the skeletal muscle tissue breaks down and releases the breakdown products into the blood. Now, these products are toxic to the kidney and can cause an AKI. Now, typically in an exam, what you will see in the question stem is a patient who has had a fall or a prolonged epileptic seizure and is found to have an acute kidney injury on admission. Other causes include prolonged immobility, compartment syndrome, seizures, and then the interaction of statins and clarithromycins, which can cause myopathy as well. So a patient may present with muscle aches and pains, confusion, typically in elderly frail patients, red-brown urine. This is quite pathognomonic for rhabdomyolysis if a patient is presenting with an AKI. In terms of investigations, because the myocytes in the muscles are undergoing cell death, they release myoglobin, potassium, phosphate, and creatine kinase, which are inside the muscle, and these would all be elevated. Now, when you do a UNE, their creatine kinase will be increased at least 5 times the upper limit of normal. Now, the higher this is, the higher the risk of injury. If the creatine kinase is raised, but not as much as 5 times, then you might want to double think whether this is the diagnosis indeed. In urinalysis, you may see myoglobinuria, so a red-brown urine, and then positive blood on dipstick. And then on their blood tests, you might see hypocalcemia, because myoglobin binds the calcium, so the excess calcium will be taken up by the myoglobin, and therefore the serum calcium would decrease, hyperphosphatemia, and then hyperkalemia. How do we manage it? So again, with an AKI, we'd give them IV fluids, we'd stop any nephrotoxic drugs, we'll treat any complications, and then monitor the patient as well. Okay, so that's us done with AKI. We will now move on to chronic kidney disease, which again is another common presentation in renal medicine. So chronic kidney disease is an abnormal kidney structure or function that has been present for more than 3 months with implications to the patient's health. So it's a gradual deterioration in the patient's kidney function. Common causes include diabetes, which is probably the most common, hypertension, an age-related decline, glomerulonephritis, and then polycystic kidney disease. Now, chronic kidney disease is often asymptomatic and it's diagnosed on routine testing. Unless the patient has very late-stage kidney disease, they might present with symptoms. So we stage chronic kidney disease according to the EGFR, which is the estimated glomerular filtration rate, and this is calculated based on the patient's creatinine, their age, their gender, and their ethnicity. And then we also use the albumin-creatinine ratio as well. So on the right here, we can see the staging. Now, this looks quite complicated, but essentially what this table is showing is the EGFR on the left-hand side, and then at the top here, we've got the albumin and creatinine ratio. So technically, if a patient has more than or equal to 90 EGFR, this is normal. However, an EGFR of 60 to 89 can also be normal, provided the patient doesn't have any other kidney disease or damage. However, someone can have an EGFR of more than 90, but because they have albumin in their urine, they would be regarded as having chronic kidney disease, whereas someone who has an EGFR of 70 with no albumin would not have chronic kidney disease. So you can't just say that just because someone's EGFR is more than 90, they automatically don't have kidney disease, because you'd also need to look at the albumin creatinine ratio. So in this slide, we can see the staging a bit better. Stages 3 to 5, anyone who has a decrease in their EGFR of less than 60, they automatically have kidney disease, and this can be diagnosed with EGFR alone because there's been a significant deterioration in their kidney function. Whereas for stage 1 or 2, you need additional evidence of kidney damage, for example, proteinuria. So if they've got an EGFR between 60 and 90 or more than 90, however, their ACR is more than 3 milligrams per millimole, or their PCR is more than 5, or they've got hematuria or an anatomical abnormality seen on ultrasound, they will be regarded as having chronic kidney disease. I hope that makes sense. So in terms of an exam, you might be required to ascertain the cause of the CKD in a patient, and there are some pathogenomic findings that might help you to do this. As we said, diabetes is the most common cause of CKD, and usually when you ultrasound a patient with chronic kidney disease, you'll see them. I'm just going to move on to this slide, if that's okay. So usually if you ultrasound somebody with chronic kidney disease, you'll see bilaterally small kidneys because their kidneys are not functioning properly. However, in diabetes, because of the effects of diabetes on the kidney, their kidneys will be large. So if in an exam you see that a patient has bilaterally large kidneys and they've got chronic kidney disease, you can assume that the cause is diabetes. You'll also see large kidneys in, for example, HIV, polycystic kidney disease, or amyloidosis, anywhere where there's infiltration into the kidney. In diabetic nephropathy, if you were to biopsy the kidneys, you'd also see something called chymostyle-Wilson nodules. So this is what you can see here, and UCL love histology. So this can easily come up, and I think this came up in a formative for us. And then in amyloidosis, this is just another exam fact, they do something called Congo red staining, and you see something called apple green birefringence. And I think we'll cover this later on a bit more, but these are just, if you see these words in an exam, this is for diabetes or diabetic nephropathy, and this is for amyloidosis. If you see small kidneys on an ultrasound, likely it's hypertension that's causing this patient's kidney function deterioration. And then you've got glomerulonephritis, which we'll talk about later on. Polycystic kidney disease, you'd see large polycystic kidneys on ultrasound. If you've got renal artery stenosis, you might see asymmetrical kidneys on ultrasound. So one kidney that's big, one kidney that's small, because of the discrepancy in blood flow to either kidney. Lupus nephritis might have anti-dsDNA antibodies. And then if you've got outflow obstruction on an ultrasound, you might see stones or benign prostatic hypertrophy, for example. So yeah, this is what we said about most patients having bilaterally small kidneys, except for diabetes, amyloidosis, polycystic kidney disease, and etc. Okay, so in terms of managing a CKD, then it usually involves a multidisciplinary team, and the focus is on symptom control and treating complications, as once you have developed CKD, you can't reverse it. So the first step is to refer the patient to nephrology. And then we want to slow down disease progression, and we'll talk about these all in a bit more detail later on, but this is essentially treating the underlying cause. We want to reduce any risk of further complications. So for example, make sure the patient is exercising, keeping a healthy weight, stopping smoking, treat any complications they have. And then if the patient has late stage kidney disease or their eGFR is very low, so for example, less than 15, we will start to prepare them for renal replacement therapy. Okay, so in terms of the referral criteria for chronic kidney disease, any patient that has stage 4 or 5 CKD is referred to nephrology. Any patient whose albumin creatinine ratio is more than 70 or more than 30, but they've got hematuria, would be referred. A declining GFR over time, if the patient also has concurrent hypertension, or if there's a genetic cause to their CKD, for example, polycystic kidney disease, all of these would require referral to nephrology. Okay, so slowing down disease progression, so treating the underlying cause, we want to optimize their blood pressure. So we want to have a target blood pressure of less than 140/90. However, if they are diabetic or they've got an albumin creatinine ratio of more than 70, their target would be even lower. So we'd manage this with blood pressure medication. If the patient is on an ACE inhibitor or an ARB, we'd stop it if we'd start the patient on an ACE inhibitor or an ARB to protect their kidneys. However, if the patient has hyperkalemia, or you see their eGFR decrease by 25%, or their creatinine increase by 30% in the time between them starting their ACE inhibitor, we'd have to stop it. We'd also ensure tight glycemic control to prevent further effects of diabetic nephropathy. And then we'd do some lifestyle management as well. So for example, stopping smoking, maintaining a healthy weight, and then ensuring that they have a low salt diet, for example, less than 2 grams of salt per day. Okay, so then treating complications of chronic kidney disease then. So if we relate this back to the functions of the kidney, because the kidneys control blood pressure, if you have failing kidney function, you might affect the cardiovascular system. So our patients are started on low dose of aspirin and then a statin such as atorvastatin, 20 milligrams once nightly orally, and this is to protect them. Protect their cardiovascular system. As we said, the kidney is involved in synthesizing EPO, which produces new red blood cells. If the kidney can't do this, then a patient might become anemic. So the hemoglobin target in a patient with CKD would be between 100 and 120 grams per liter. If it is less than this, we might need to replace their iron. Now, depending on how bad their anemia is, we might also need to use IV iron. If their hemoglobin falls below 100, we'd also need to give them EPO, erythropoietin. However, we want to ensure that the patient doesn't have iron deficiency anemia when we're giving them EPO. So we'd always do iron studies first, and then if the ferritin is normal, we'd give them their subcut EPO. Acidosis. we'll give them sodium bicarbonate to combat that, because the target bicarbonate would be more than 20 millimoles per litre. If the patient has edema, we want to salt restrict them, as well as giving them loop diuretics or water tablets such as furosemide. And then one of the key things that can happen in the kidney is something called bone mineral disorder. So as we discussed, the kidneys are involved in activating vitamin D. If there is no active vitamin D, there would be less absorption of calcium from the diet and then less phosphate excretion. And as a result, the parathyroid hormone can become stimulated, which further increases bone resorption. And this is secondary hyperparathyroidism, and it leads to effects on our bone. This can lead to osteomalacia, so soft bones, osteoporosis, brittle bones, and then osteosclerosis as well, which is a hardening of the bones due to dysregulated formation. So the first line treatment for bone mineral disorder would be a low phosphate diet. And then if the patient is not controlled on this, we might give them phosphate binders to remove the excess phosphate from their bloodstream. We might give them vitamin D analogues such as alpha calcidiol or calcitriol. We might give them calcium mimetics, or they might need parathyroidectomy. And if the patient develops osteoporosis, then we'd want to protect their bones with bisphosphonates. Patients can also get restless legs in chronic kidney disease, in which case we treat them with clonazepam. And then, as we discussed before, ACE inhibitors is the first line for proteinuric renal disease in terms of renal protective effects. However, we can only give it if there are other parameters such as creatinine and their EGFR are not affected too much. So if, despite all of this, the patient still has quite severe kidney disease, stage 5 or an EGFR less than 15, we'd start to prepare them for renal replacement therapy, and that's going to be covered in the next section by Ameerah. Now, before Ameerah starts, please can you guys fill in this feedback form, just so we know if these tutorials are actually helping and what we can do to change it. So we'll just give 1 minute or so to fill this in, and then Ameerah can take over. Thank you, guys. Ameerah, you can take over.
Okay, thanks so much, Sumayyah. So I'm just going to share my screen. Okay, can everyone see this?
Yep.
Okay.
Yes.
So I'll just be covering renal replacement therapy, and then we'll move on to urinary tract infections as well as polycystic kidney disorder. So renal replacement therapy is something that is considered an end-stage renal failure. So this is also defined as an EGFR stage 5. It can also be used in some cases where there are very severe complications of AKI, but by far the most common use is in end-stage renal failure. So broadly, there are two types, so dialysis and renal transplantation. And then within dialysis, you can have two types as well, so hemodialysis and peritoneal dialysis. So I'll go into this in a bit more detail. But before doing that, I'll just give you a bit of under a minute to look at this SBA. Okay, would anyone like to volunteer a guess?
It's just a guess, but C.
Yep, okay. So yeah, that's absolutely right. So HD is very time consuming. So oftentimes people spend hours in the treatment center connected to the machine many times a week. And then in the AVF, this is usually just needed in one arm. Usually the radiocephalic fistula is preferred because it's a bit more distal. So it's a bit simpler to create and also easier to access. And it also means that more proximal areas are preserved for fistula creation if necessary. And finally, HD cannot actually be continuous, only a peritoneal dialysis can be. So hemodialysis has a lower infection risk than peritoneal dialysis. So when it comes to dialysis, broadly, again, two types, HD and PD. The decision about which one is based on many different factors, such as individual preference, lifestyle, comorbidities. It often involves a multidisciplinary team. And of course, extensive discussion with the patient themselves. So firstly, I'll talk about hemodialysis. So this involves blood being filtered by a hemodialysis machine, usually about 4 hours a day to maybe 3 days a week, but this can vary depending on person to person. That's just a typical regime. The blood is taken from the body, it's passed through this sort of dialysis machine, and then it's pumped back into the body. And basically in the machine, it's passing through the semi-permeable membrane. So in doing so, the solutes filter out of the blood across the membrane and into a fluid known as the dialysate. And it's basically the concentration gradient between the blood and this dialysate fluid, which allows diffusion to occur. And usually anticoagulation is also given at the same time with citrate or heparin in order to prevent the formation of blood clots. And then in terms of how the blood is actually accessed from the body, so this can be via AV fistula or via a central venous catheter. So firstly, I'll talk about AV fistulas. So these involve creating or connecting a vein and artery together. And so this means that the fistula has very, very high blood flow and quite good longevity. It takes roughly 6 to 8 weeks to develop. And if the vessel itself is too small, then you could consider an AV graft, but I'm not sure if that's as common. So AV fistula is definitely much more common. So again, as I mentioned earlier, it is radiocephalic, but you can also consider a brachiocephalic fistula at the antecubital fossa, connecting the brachial artery to the cephalic vein. And brachiobasilic fistulas may also be considered, but again, not as likely, just because they're more complex. So during renal placements, I would really encourage that you take the time to really examine these fistulas. You can check the skin integrity, if there are any aneurysms. You can also palpate it to assess for a thrill, so you'll feel sort of a fine vibration over the anastomosis. And then you can also auscultate it for a machinery murmur. Now, in terms of so we'll move on to peritoneal dialysis in a moment, but in terms of the complications, broadly, there are things like aneurysms, infections, thrombosis, stenosis. You may also see Steele syndrome and high output heart failure mentioned sometimes, particularly in exams, and the patient may also experience swelling in the fistula arm following surgery. So just a brief comment on Steele syndrome. So this is when inadequate blood flow to the limb happens distal to the fistula. So basically the fistula is actually stealing blood from the rest of the limb, and the blood itself is diverted away from the part of the limb it was supposed to supply, leading to this ischemia. And so instead what's happening is that it's just flowing through this fistula and into the venous system. On the other hand, high output heart failure is because the blood is flowing very quickly from the arterial side to the venous system through this fistula, and so there's a much more quicker return back to the heart, which increases preload. And so this then leads to hypertrophy of the muscle and ultimately heart failure over time. And finally, another thing not mentioned here is that you actually do need to create access in the first place, and it can take time for AV fistulas to mature. So this needs to be quite planned. It needs to be done well in advance. So it's not very suitable for emergency scenarios. So on the other hand, you can consider CVC as a method for hemodialysis. So if the person doesn't have an AV fistula, or maybe they have a problem, meaning that they can't have a functioning fistula, another option is to consider a central venous catheter. So there are broadly two types, so non-tunneled and tunneled. So non-tunneled ones are mostly used as a temporary measure until a more permanent means of access can be established. So usually it's used in emergencies, whereas tunneled CVCs are placed actually like right below the skin. They can be used as more of a long-term measure. And so this is usually inserted into the subclavian or jugular vein, and the tip is in the SVC or right atrium. And usually, as you can see here, 2 lumens. The red one is usually for blood actually exiting the body, and the blue for entering. And they're also small cuffs. You can't really see in this picture. I'm sorry, it's so small. But there are tiny cuffs over here which lie just underneath the skin, and that really helps to with adhesion, promoting healing, and also reducing infection risk. And so CVCs also have similar risks of blockage, clots within this catheter, infection, as well as recirculation of blood. So all of these things, they have quite similar risks between the two means, but they're quite unique to peritoneal dialysis, which I'll move on to in a moment. So peritoneal dialysis, on the other hand, is another type of renal replacement therapy, and it's sometimes used as a stopgap to hemodialysis. It can also be used for patients who maybe don't want to visit the hospital thrice a week. And in this case, the fluid is actually inserted into the abdomen, and the peritoneal membrane within the abdomen itself acts like a filter for the blood. And this works because certain solutes can be added to the fluid, like dextrose, and this then allows for ultrafiltration from the blood across the membrane and then into the solution. And then after that, the solution can be replaced. And then the actual catheter is known as a Tenkov catheter, which is a tube basically inserted into the peritoneal cavity, and it has one end on the outside to allow access to insert and remove the solution. So broadly, two types of peritoneal dialysis. So there's continuous ambulatory PD or automated PD. So with continuous ambulatory PD, the dialysis solution is almost always in the peritoneal cavity. Usually someone can have about 4 exchanges of 2 liters of fluid a day, and the dwell time of this fluid, so however long it stays within the cavity, can last anywhere from 4 to 8 hours. It can be even longer at nighttime. So most people prefer this option because they can just go about their daily activities. And then the other option is automated PD. So this is where the machine continuously replaces the dialysis fluid, and it performs anywhere from 3 to 5 exchanges over 8 to 10 hours. And the dwell actually happens when the person is lying down, so they're supine. So this means that the rise in intra-abdominal pressure is slightly lower compared to continuous PD, where they are sort of ambulating, so they're walking around. So in terms of complications associated with peritoneal dialysis, so you do have risks of infections such as peritonitis, and this is the infections in a high sugar environment are simply common. So usually this is due to things like coagulase negative staph, such as staph epidermidis, but other causes are also not uncommon. So staph aureus, for example. So you would treat this with antibiotics, which cover both gram-positive and negative bacteria, such as vancomycin, teicoplanin, and ceftazidime, and you can add them to the dialysis solution, or you could consider vancomycin added to the dialysis solution and ciprofloxacin taken orally. So just a quick mention, in SBAs, you may see sort of a woman with a history of end-stage renal disease on CAPD for the past 12 months. They may come in feeling quite unwell with tummy pain, a fever. She may also describe her last bag looking cloudy. And so that's usually a characteristic sort of stem for someone presenting with peritonitis. Other complications include sclerosing peritonitis. So this is where there's thickening and scarring of the peritoneal membrane with associated inflammation. There's also ultrafiltration failure. So this can involve the dextrose actually being absorbed into the body, which then reduces the concentration gradient, which means that ultrafiltration is overall less effective. And this can sometimes lead to weight gain as well. I would really recommend looking on PASMED for a very long list of complications for RRT, including things like dialysis disequilibration syndrome. So that's something that's commonly tested. It's quite mean, but it is a weirdly specific exam topic that can be tested. So just moving on, some general complications associated with both include cardiovascular disease, malnutrition. There are important psychosocial implications associated with dialysis, and I'd really encourage, there are loads of patient information leaflets which have quite good information on how patients may access support options for this. Osteodystrophy, infection, amyloidosis are also further complications. And just a quick mention, hemofiltration, hemodiafiltration are not covered in this tutorial, but I would signpost you to look into it in a bit more detail. So really quickly, indications for emergency dialysis can be remembered as AEIOU. So firstly, we have acidosis. So this would be a metabolic acidosis where the pH is less than 7.1. Electrolytes, so refractory hyperkalemia or rapidly rising potassium levels. Intoxicants or drugs, so these can be remembered with a mnemonic SLIME, so salicylates, lithium, isopropanol, methanol, ethylene glycol. overload, so fluid overload, which is refractory to diuresis, and then uremia with signs and symptoms such as pericarditis, encephalopathy, neuropathy. So in this case, as I mentioned, the temporary dialysis catheters can be inserted here, so non-tunnel CVC, for example. These generally give access for about 45 days, I think, but this can vary. And the most common complication would be things like bleeding, maybe viscous injury, so to the vessels or lungs. There may be catheter malfunction causing clots or air embolisms and infections. So infections are more common with femoral vein catheters. So just moving on, in terms of renal transplantation, so in this case, there are loads of different types. So living donors often have the best survival rate, where I think it's about 95% in 1 year. But living donors can be live related or unrelated. And on the other hand, there's also diseased donors. So this is also known as a cadaveric donor. This has a slightly lower survival rate, and I think it's 90% roughly, and it's much lower at 10 years compared to living donors. And there are different subtypes. So you can have donors after brainstem death. So this is where there's brainstem death. However, cardiovascular support is still persisting. And then donation after cardiac death, where there's no active circulation, and this has an increased risk of delayed graft function. And then expanded criteria donor. So this is typically an older kidney from someone who has a history of CVA, BP problems, or CKD. So this can influence long-term prognosis. Now, there are a few contraindications. So absolute contraindications would be things like metastatic cancer because the graft is unlikely to survive as long. Relative contraindications include congestive cardiac failure or cardiovascular disease, and temporary contraindications can mean acute active infection, HIV with viral replication, and unstable CVD. Now, just a side point, it's also important to assess transplant suitability. So things like virology status, CVD, TB, their blood haplotypes, so ABO and HLA antigens would be considered. And I think with HLA matching, in any case, the importance is different for different HLA antigens. So the most important would be HLA-DR, followed by HLA-B, and then HLA-A. And this also means that any live vaccines that the patient still needs to receive would be given at least 4 weeks before the transplant, and no live vaccines would be given after the transplant. This is particularly important because the first 3 to 6 months after the transplant are a period of very, very heavy immunosuppression. So that brings me on to the next subtopic. So with post-transplant immunosuppression, you don't need to know everything, but it is important to be aware of the different types, the main side effects. So basiliximab and taclizumab, I'm not sure if I'm pronouncing them correctly, but these are medications which block IL-2 receptors on T cells. Tacrolimus, cyclosporin are calcineurin inhibitors, so they do prevent T cell activation and proliferation, but they are nephrotoxic. Mycophenolate mofetil and azathioprine are antimetabolites, so these have their own side effects such as anemia, leukopenia, gastrointestinal toxicity, and finally steroids as well, such as prednisolone. So postoperatively, short-term immunosuppression can involve prednisolone, whereas long-term options would include things like tacrolimus, cyclosporin. A commonly tested exam fact for cyclosporin is that the side effect is gum hyperplasia. Azathioprine can also cause a heightened risk of skin tumors such as SCCs. And tacrolimus can also cause alopecia. So in general, immunosuppressants also increase your cardiovascular risk. So things like hypertension, hypercholesterolemia, post-transplant diabetes. You may see signs of this on the ward even. And then immunosuppression is not only necessarily post-transplant, it can also happen pre-transplant. So with things like Campath, so that's also known as alemtuzumab, which is an anti-CD52. So again, you don't need to know everything, but it's just important to be aware of the main types of immunosuppression. So when it comes to the renal transplant signs, it's important to have a look on the wards. You may detect certain scars, such as the Rutherford-Morrison scar, suggestive of a transplant, or you may see scars suggestive of previous treatment, such as that of a tunnel cuff scar or a peritoneal dialysis scar. And usually both kidneys will still be present, and the third one will just be added a little bit further down below. You can feel as a sort of a mass in the lower quadrant. You may also be able to ballot the old kidneys if they're large as well. And then immunosuppressants can also cause skin cancer, specifically SCC. So you may want to think about maybe doing a full exam just to look for signs of skin cancer or excisions, or ask about this in the history. So here's a picture. So squamous cell carcinoma over here and basal cell here. You will do more on this in year 5, so you don't necessarily need to remember what they look like, just that there is a strong association. You may notice a tremor, which is associated with certain medications given as part of post-transplant immunosuppression, calcineurin inhibitors, and then if they're on long-term steroids, you may notice signs of Cushing syndrome. And finally, gum hyperplasia associated with cyclosporin. Okay, so just a quick note on the exam as well. You may also want to consider assessing fluid status, so looking for signs of ascites, bruits, checking skin turgor. You may notice signs of anemia, so pallor, angular cheilitis, chorlinikia, and the skin may show signs of a uremic tinge, bruising, scratch marks, or even a vasculitic rash, depending on what the underlying cause of the end-stage renal failure was. And you can also ask patients about what type of diet they're on. So this is a renal diet is commonly assigned to patients who have dialysis or if they have impaired kidney function. So this would involve restriction of things like sodium, potassium, phosphate, also fluids. And you may also see caloric supplements. So just moving on now to complications. So there are loads of complications associated with transplantation, and they're not by all means covered here. So generally be aware of post-op complications for any type of operation. So things like bleeding, clots, infections. Hernia is a bit more specific to abdo surgery, and then more things more specific to renal transplants. So general tip when discussing complications, use a system. So you can use immediate, early, or late complications, or you could do it by anatomy. In this case, we're kind of dividing it by general surgical anesthetic complications with any operation, and then those more specific to the renal transplant. And so those related to the graft are kind of delayed graft function. You can also have acute tubular necrosis of the graft, urinary leakage, UTIs. There is also an important topic of rejection. So hyperacute rejection happens within minutes to hours, and it's usually because there are pre-existing antibodies against the ABO or HLA antigens. This is a type 2 hypersensitivity reaction, and this leads to this widespread thrombosis of the graft vessels, which then means that there is ischemia and necrosis of the transplanted organ. So no treatment, unfortunately, is possible in this case, and the graft has to be removed. And then in acute cases, usually this is quite asymptomatic and is usually picked up by a rising creatinine, pyuria, and proteinuria. Usually is diagnosed by renal biopsy, and so you can consider management with steroids and immunosuppressants. So just again as a side point, differentials of rising creatinine in treated patients can include things other than rejection, so things like obstruction, drug toxicity perhaps, as well as acute tubular necrosis. So chronic rejection is mediated both by antibodies and cells. So this can then cause fibrosis to the transplanted kidney, and this may also mean recurrence of the original renal disease. This is really common in MCGN, but also IgA nephropathy. And then finally, immunosuppression. There is a heightened risk of infections. So within the first 6 months, typically things like CMV and PCP, so more opportunistic infections, whilst in the 6 to 12 months, it's usually more community-acquired infections, late viral infections. You can also have reactivation of latent viruses like HSV or HBV. There's also an increased risk of malignancy, as pointed to previously. So it's just important to advise on wearing sun cream, covering up in the sun. There's also risk of post-transplant lymphoproliferative syndrome, as well as solid organ tumors, such as certain gynecological cancers, and finally CVD as well. So that's the end of the renal replacement therapy section. So I'm now just going to move on to UTIs. I'm just going to give you a moment to answer this SBA. Anyone want to give it a go?
Yeah. So I would rule out A, B, and C because it's suggesting it's a UTI.
Yep.
and usually treat with trimethoprim or nitrofurantoin. And I think the NICE guidelines is D, nitrofurantoin.
Yep, exactly. Well done.
Okay.
Yeah, so exactly. So if she were to be pregnant, then it would be 7 days, but because she's not, it would be 3. This is an uncomplicated UTI, so you'd think about nitrofurantoin or trimethoprim for 3 days only. So yeah, that's great. And then basically UTIs. So before I move on to presentation, there are sort of various different definitions of this, but one that we were taught this year was that it's an inflammatory response of the urothelium to bacterial invasion, and there's this criteria known as a CAS criteria, which defines it as over 10 to the power of 5 colony-forming units per mil in the midstream urine sample. So this isn't necessarily applied. It's been greatly challenged. So generally, any number of bacteria in the urine, in the presence of symptoms in particular, is sort of treated as a UTI. So in terms of presentation, it's really common. It's more common in women because the urethra is shorter and it's more proximal to reproductive organs and the anorectal system. And so this reduces the actual geographical distance for bacterial ingression. In terms of whether it's complicated or uncomplicated, so uncomplicated just means that you have an infection in the urinary tract with normal morphology and function, whilst complicated means that there's an infection in someone who has factors which increase the chance of bacterial invasion, or they decrease the effectiveness of treatment. So for example, if someone's had lots of procedures to the urinary structures or they have congenital abnormalities, this distinction is actually quite important because in complicated UTI, even if it's just sort of a foreign body, for example, there is a higher chance that the UTI can actually be cured by correcting this abnormality. So removing the foreign body or surgically correcting a bladder diverticulum that's there congenitally. Yeah, and then whereas in uncomplicated, usually, so for example, if you have someone who has recurrent bladder infections, so cystitis, you may not necessarily be able to definitively cure the UTI because the symptoms can recur despite treatment. And so you'll often also see being male as an inherent cause for complicated UTI. So we were taught, technically speaking, being male doesn't mean that the UTI is inherently complicated, but rather it is treated as a complicated UTI because usually there's an underlying cause for them to have an infection. So like urethral stricture or benign prostatic hypertrophy, which then leads to incomplete voiding, and there's increased risk of, therefore, urinary stasis. So it increases the risk of infection. So other than that, UTIs can be divided into 3 different types. So you have cystitis, inflammation of the bladder, prostatitis of the prostate, and pyelonephritis of the kidney. So this typically affects the lower urinary tract as opposed to the upper. And cystitis, there's a characteristic triad of or syndrome of frequency, dysuria, so painful urination, and urgency. And then pyelonephritis usually happens due to ascending infection from the lower urinary tract. So that being said, I'm now going to move on in terms of the actual causative organisms. So they tend to be caused by gut or vaginal flora and gram-negative species. So E. coli is by far the most common. It's about 80% in uncomplicated, whereas in complicated UTIs, it's a little lower. So mostly so other routes of infection can include also via the blood, but this is way less common. And then other than that, there's also Staph saprophyticus, which is a gram-positive organism. This is seen in sex workers, can be referred to as honeymoon cystitis, but I think this is more so an exam fact. There's also Proteus mirabilis, which results in this fishy odor characteristically, Klebsiella in alcoholics, in diabetes, IV drug users. Pseudomonas aeruginosa is quite common in catheterized patients as well. Proteus mirabilis can cause certain renal stones known as staghorn calculi. This is a type of kidney stone which is so large it actually obstructs the entire renal pelvis. So I'm just now going to move on to the risk factors. So this is a type of system you can think about when considering the different risk factors. So usually with increased inoculation, things that increase this would be sex, incontinence, and constipation. Increased bacterial binding can be caused by spermicides, as well as low estrogen, menopause, and hygiene. Increased bacterial growth, so diabetes, immunosuppression, catheters, stones, and pregnancy, and then finally reduced urinary flow due to dehydration and MS. So this is quite common in the elderly, unfortunately. So Moving on to investigations, so always important to categorize by bedside bloods and imaging. So with regards to bedside tests, you can just general from the end of the bed, what can you actually see? Are there signs of sepsis? On urine dip, you can see positive nitrates and leukocytes. You may also potentially see hematuria and proteinuria, but not necessarily. So nitrates usually occur because lots of UTI-causing pathogens are gram-negative, and they contain something known as nitrate reductase, which converts the nitrates to nitrites. UTIs, however, can also be caused by bacteria that don't actually have that enzyme. So just because someone doesn't have positive nitrites, that doesn't mean that they don't have a UTI. And finally, pregnancy test is also really important because not only will that guide antibiotic choice, which I'll come on to in a moment, it can also influence the actual duration of the antibiotics. And finally, MSU for MCNS is really important because in complicated UTIs in particular. So you wouldn't necessarily always do an MSU. Now, in terms of blood cultures, typically you do FBCs that will show leukocytosis, USNEs, LFTs, CRP, blood cultures if there are signs of sepsis. And then with regards to imaging / specialist investigations, USS renal tract with post-void residual volume would be considered here. This is especially important in children because they often don't have UTIs, so you'd need to think about underlying congenital causes for this, for example. And then if there's persistent hematuria, you would also consider a 2-week weight referral, and you'd also consider referring to urology if there was a failed response to therapy or there were low recurrent episodes. So in terms of the treatment, this is sort of a summary of the antibiotic guidelines from NICE. Conservative advice, however, would involve increasing fluid intake, avoiding before and after intercourse. If they're postmenopausal, you can consider topical estrogen because this alters the vaginal flora favorably by promoting the growth of actual commensals, like things like lactobacilli, and that can form a barrier from uropathogens. And then in women, usually if it's uncomplicated, then you would consider 3 days of nitrofurantoin or trimethoprim. In men, this would be the same, but 7 days because it's treated as a complicated UTI. And then if it's recurrent, you would consider urology referral. If there is pyelonephritis, you would consider broader spectrum antibiotic because there's kidney involvement, and these are usually treated very aggressively because with each bout of kidney infection, some nephrons are lost, and so there's a higher risk of urosepsis. Whereas with cystitis or lower urinary tract infection, you can use a bit more of a narrower spectrum antibiotic because there's a relatively lower risk of severe long-term harm. Now, in terms of pregnancy, it depends broadly on whether the person is symptomatic or asymptomatic in terms, but usually what happens is a urine culture is sent in all cases, and first line is usually nitrofurantoin, except if they're closer to term, and second line would be things like amoxicillin or cefalexin. Trimethoprim, importantly, is teratogenic in the first trimester, so you wouldn't use it in that point because it's an antifolate, so it can increase the risk of neural tube defects. And as I mentioned earlier, avoid nitrofurantoin in the 3rd trimester as it can cause neonatal hemolysis. If someone has asymptomatic bacteriuria and they're pregnant, then usually what happens in the first antenatal visit anyways is that a urine culture is performed. And this asymptomatic bacteriuria, if they're pregnant, is treated anyways. So that's either nitrofurantoin if they're early on, or amoxicillin or cefalexin, and that's for 7 days. And this is just because there's a high risk of progression to acute pyelonephritis if it's not treated. And then finally, there needs to be a urine culture sent after treatment, just as a test of cure. And finally, catheter in situ. So in this case, because you're introducing a foreign body to the urinary tract, they'll by default have bacteria growing on the cultures. So you won't necessarily treat it if it is asymptomatic because you're expecting for cultures to grow something. But if they are symptomatic, then you would consider treatment with 7 days of antibiotics. So just one more thing, don't prescribe trimethoprim and methotrexate together, and this is because both of them are antifolate, so there's a risk of marrow aplasia. And other sort of antibiotic regimens do exist if someone has uncomplicated recurrent UTIs, so you can consider self-initiated intermittent courses of antibiotics. You can also consider one therapeutic dose and then long-term low-dose prophylaxis, as well as antibiotics used depending on sexual intercourse. So just moving on now to polycystic kidney disease, very briefly. So there are two types, so PKD 1 and 2. 1 is the most common, so about 75%. It tends to be more aggressive, so a person tends to reach end-stage renal failure much more quickly, typically by the age of 50. And then in terms of screening, this is usually done by abdominal ultrasound, especially if they're over the age of 20. And this just involves counting the number of cysts, and depending on the number of cysts, you can then diagnose. I'll come on to that in a moment. The prevalence, it does affect 1 in 1,000 Caucasians. So it's the most common inherited cause of kidney disease. In terms of what you may see is in terms of the presentation, so things related to the rupture of the cyst, so blood in the urine, pain in the flanks. When it comes to if the cysts become infected, then flank pain, fevers, urinary signs and symptoms. You may see someone have recurrent UTIs or maybe even stones. And PKD, this is commonly tested in exams, it can also affect other parts of the body, not just the kidneys. So cysts may happen in the liver. And then berry aneurysms may also occur, which can then cause arachnoid hemorrhage, as well as mitral valve prolapse and aortic regurgitation. In terms of the investigations, so that's the specifics on how many cysts you would need in order to diagnose ADPKD. I'm not sure if this is as high yield, but it's quite important to note that ultrasound would be used as the diagnosis approach. And then with regards to management, high water intake, about 3 to 4 liters a day, low sodium diet, monitoring U's and E's as well as BP would be important. This also in itself, okay. So MRI screen would also be considered for berry aneurysms in age 65 plus. And then you would also have a target of less than 130/80 for the BP control. And typically this would be with ACE inhibitors or ARBs, provided they're not contraindicated. But this doesn't actually slow progression. So tolvaptan is sort of, I think, the main drug that actually has been found to slow progression. But this would only be considered for specific patients. It would only really be initiated by a specialist to begin with. And then you may also consider planning for RRT because this disease, unfortunately, does slowly progress to end-stage renal failure. Okay, so that's the end of my section. So please feel free to leave your feedback if you have time. Just for the interest of time, I'm going to stop sharing and let Shazmen go ahead.
Okay, hello everyone. I'm just gonna share now. Just give me a minute. Can everyone see this? Just wanted to confirm. Can everyone see this? The slides?
Yep, I can see.
Okay, perfect.
Yeah, I can see.
Lovely. So I'm going to be going through glomerulonephritis as well as nephrotic and nephretic syndrome. I just want to preface these slides by saying that this topic can be quite difficult, but my advice would be don't get too bogged down with all the different types of glomerulonephritidis. Focus on the high yield ones and try to get yourself acquainted with the buzzwords. For example, a lot of these conditions have specific histological features, and even if your histology isn't too good, as long as you know the specific feature, it might come up in an exam and you might be able to then relate it to a histology slide that they show and therefore guess the right answer, if that makes sense. So yeah, most of the slides are going to be quite busy, but that's just so that we can give you like the most information that you need, the most relevant information, and then you can go through the minutiae in your own time. So, glomerulonephritis is characterized by inflammation of the glomeruli and the nephrons. So, essentially, what happens is that the damage to the glomeruli, it leads to lack of blood flow through the kidneys, and as a result, you get hypertension. The filtration mechanism of the kidney is also affected, and as a result, you get some level of protein and/or blood in the urine. And sometimes these patients also experience AKI because of this lack or this loss of So these glomerulonephritis, they exist on the spectrum. So they can present with proteinuria, hematuria, or both. And the definitive diagnosis is on renal biopsy, except in one condition. So does anyone know what condition you wouldn't do a renal biopsy in? Let's give a guess.
An AKI.
AKI. So AKI is actually a symptom. It's not actually a like a type of glomerulonephritis, but that is a good guess. So actually, the condition where we won't biopsy is in minimal change disease. So this is largely a childhood disease, and in this case, this condition responds really well to steroids. So we'll give the patient steroids, and if they stabilize and the condition improves, then we'll assume that it was actually due to minimal change disease. And the reason that we avoid a renal biopsy is because it's quite invasive, and you don't really see much on the renal biopsy. So that's why we won't do it in minimal change disease. So all of these glomerulonephritis can progress to CKD, and they can also progress to kidney failure, except in minimal change disease. So on the right is a diagram which just categorizes the different types of glomerulonephritis into proliferative and non-proliferative. So you can kind of go through these in your own time, but I'm going to quickly explain what the terms mean. Proliferative is where there's an increase in the number of cells in the glomerulus. And typically this is going to present with nephritic syndrome. So that's where you have blood in the urine. Whereas non-proliferative is the opposite. So there isn't an increase in the number of cells. And so it's going to present with more of a nephrotic syndrome, where there's predominantly like loads of protein in the urine. And this diagram just explains why I was talking about that glomerulonephritis can exist on a spectrum. So, for example, minimal change nephropathy is a purely nephrotic syndrome, but then there are other conditions where you can have kind of an overlap between the two. And the reason why we use the terms nephrotic and nephritic is just to kind of classify the disorders based on the main symptom that they present with. So, for example, if a patient has membranous nephropathy, then they largely present with proteinuria. That's the main kind of symptom, but then they actually not membranous nephropathy, but something like diabetic nephropathy, then they may also have a bit of hematuria. So we would just classify it based on the main symptom. Okay, so let's talk about nephrotic syndrome. It's actually characterized by a triad of three main things. Firstly, you get proteinuria, which is where there's loads of protein in the urine, and typically you're not supposed to see much protein at all in the urine, but in this case you get around or more than 3.5 grams in 24 hours. You also see hypoalbuminemia. So albumin, as we know, is a protein that also leaks out of the kidney into the urine, and so you typically see less than 30 grams per liter. And then you see edema as well. Just to mention that proteinuria is basically, you'll be able to visibly see it, for example, if the urine is frothy or smells slightly funny. So edema, let's just quickly talk about why we see edema. So essentially, proteins that are in blood vessels, they actually cause this kind of oncotic pressure. So if there's more protein in the blood vessels, there's a higher oncotic pressure. If there is reduced protein, there's reduced oncotic pressure. So essentially, a higher oncotic pressure is what keeps water in the blood vessels. So when all of these proteins are leaking out, the oncotic pressure is reduced, and as a result, water then leaves the blood vessels, and so you'll see edema. And this can happen anywhere. So typically in adults, it will be peripheral edema. In children, it will be more facial edema, periorbital edema. But this can happen really anywhere. So patients may present with ascites or genital edema, things like that. So the underlying pathophysiology for most nephrotic syndromes, if not all, is injury to podocytes. So I'm just going to explain what these are. So if you look at this diagram here, in the kidney, you have your blood vessels, which are lined with endothelial cells. And in between, you have these really tight gap junctions that allow only specific things through. And then next to it, you have the basement membrane, and then you have podocytes. So these are basically cells that look like octopuses. This is kind of the body, and then the tentacles kind of wrap around the basement membrane. And the podocytes basically act like sieves. So they only allow certain molecules which are kind of small, such as water and kind of ionic salts to pass through. And everything else, like larger molecules, red blood cells, other proteins, they're not allowed to pass. And part of this mechanism is because these foot processes, they contribute to this negative charge along the basement membrane, and so it repels a lot of the substances that we wouldn't want to be filtered through the kidney. And this is just another diagram which shows a similar thing. And when there's injury to these podocytes, then their capacity to act as a sieve is reduced, and so you see unwanted things in your urine, such as proteins and red blood cells. Well, in the case of nephrotic syndrome, you wouldn't typically see red blood cells, but you would see proteins. So in addition to these three things, you may also see complications in patients, and this is especially the case if the nephrotic syndrome goes on for a long time and isn't treated. So firstly, you'll see thromboembolism. So this happens when you have loss of anti-clotting factors such as antithrombin 3 and protein C and S. And loss of these things leads to a higher activation of clotting factors like factors 2 and X. And so patients may then develop VTE, DVT, and even renal vein thrombosis. And this last one, renal vein thrombosis, we characterize it or we diagnose it if there is a tetrad of loin pain, hematuria, raised LDH, and AKI. So patients who are at high risk of developing thromboembolism, we may consider giving them low molecular weight heparin. Secondly, patients may develop hyperlipidemia. So in this case, you have increased LDL or cholesterol as well as triglycerides in the blood. And it's been postulated that the reason this might happen is because, as I said, there's reduced protein in the blood vessels, so there's reduced oncotic pressure, and the liver responds to this by increasing its synthesis of triglycerides and other lipids. And it may also be due to defective breakdown of lipids as well. And finally, patients with nephrotic syndrome may experience recurrent infections or may be more susceptible to infections. So this might be caused primarily by the nephrotic syndrome itself. For example, if there's loss of IgG, like antibodies, in the urine, but also it can also be a consequence of some of the treatments that we give to treat nephrotic syndrome, which tend to be immunosuppressive. So patients may get urinary infections, respiratory infections, also things like peritonitis, empyema, so like fluid collections in the lung. And so we try to make sure these patients are vaccinated with the pneumococcal vaccine as well. So now if we move on to causes of nephrotic syndrome, so this can be divided into primary and secondary causes. So let's start with minimal change disease. This is the most common cause of nephrotic syndrome in children. And the underlying pathophysiology is that you have T cells and cytokines which cause damage to the glomerular basement membrane. And as a result, there's the glomerular basement membrane, it becomes more permeable to albumin. So overall, you see this kind of very highly selective proteinuria where not every single type of protein leaks out. It's only medium-sized proteins such as albumin. And in addition to this, patients are normally normotensive, so they don't experience hypertension. And just to add that most cases of minimal change disease are idiopathic, but there are certain drugs such as rifampicin and NSAIDs that can cause this type of nephropathy. And in addition, having conditions like Hodgkin's lymphoma, thymoma, or infectious mononucleosis can also lead to minimal change disease. So if we do, I know we said that we don't typically do renal biopsy in minimal change disease, but if you were to do so, then under light microscopy, everything would look normal. That's why it's called minimal change disease. But under electron microscopy, there'll be basically flattening of the podocytes. So this flattening or effacement means that the frequency of slits in the in the podocytes, it's reduced, and as a result, the ability of it to act like a sieve is like severely reduced. Treatment for this is steroids. So steroids are a really good way of managing this condition. If patients experience frequent relapses or they have steroid-dependent disease, then you can give them cyclophosphamide or cyclosporin. And here, just on the right, is just a diagram comparing what a normal kind of glomerulus and podocyte system looks like compared to minimal change glomerulonephropathy. So you can see here these very distinct slits that act like a sieve, whereas here it's all flattened out, and so it means that more unwanted kind of proteins and things can leak through. So focal segmental glomerulosclerosis, if we move on to that now, this is where you have certain glomeruli in the kidney are affected, and just small sections of them are affected as well. They're like scarring. And classically, it's associated with lymphoma and HIV. So sometimes in SBAs, the stem might reference a patient with HIV who's coming with a nephrotic-like syndrome. One kind of niche fact to remember is that if these patients if these patients are treated and then later have a kidney transplant, then the risk of their disease coming back or of them experiencing FSGS is quite high. So in terms of renal biopsy, if we do a biopsy, then it will show like scarring of certain segments. So it's because it's not the entire glomerulus, it's known as focal sclerosis, and we can see it here because the rest of the glomerulus looks normal, but then this particular section looks quite sclerotic and dense, like kind of packed together. And treatment, again, is similar to minimal change disease. So you'd give patients steroids or cyclophosphamide/cyclosporin if they're resistant to steroids. And the third type of nephrotic syndrome is known as membranous glomerulonephropathy. And this is where you have antibodies to podocytes, which are these things right here, which I was talking about. It's important to know that it's antibodies to podocytes because I'm going to later be talking about another condition where you have antibodies to the glomerular basement membrane itself. And this condition can be idiopathic or secondary to other things such as malignancy, infection, immunological disease, or a certain drug. And the way that we diagnose it is by testing to see if there's any anti-phospholipase A2 antibodies present, and also doing a renal biopsy where you classically have this spike and dome appearance of the glomerular basement membrane if you stain it with silver stain. And as well as this, the glomerular basement membrane is diffusely thickened and you have deposits of IgG and C3. So we know that complement, it's involved in the formation of complexes, and so you'll see those in the glomerular basement membrane. And then obviously, because we know that this condition involves antibodies, you're also going to see deposits of those in the kidney, in the biopsy. And we can see this here. So this is what a normal podocyte looks like. But when you have membranous glomerulonephropathy, then you have these antigens. So basically, every cell in the body has antigens. Some are self, and some can be kind of foreign. And in this case, it's kind of autoantibodies. So it's antibodies that our body produces against itself. And then you have these immune complex formations, and that's what leads to the nephrotic syndrome. In terms of treatment, if it's an idiopathic presentation but we don't find causes, then we can give ACE inhibitors or ARBs as well as diuretics. Otherwise, if we know what the cause is, we would treat the underlying cause. And so in terms of prognosis, a third of patients will develop chronic kidney disease, a third will respond to cytotoxics, and 1/3 will just resolve. Okay, if we now move on to secondary causes of nephrotic syndrome, so there are kind of three main types. Firstly, diabetes. So we know that diabetes can have microvascular manifestations. So in the kidney, it's known as diabetic nephropathy. And classically, on a renal biopsy, you will see these chemosteined-Wilson nodules, which are shown here. So you can see kind of the rest of the kidney looks normal, and you have this massive nodule right here. And you also have this kind of a microaneurysm as well, which is pointing towards the fact that this patient has diabetic nephropathy, because we know it's a vascular disease. And also you have microalbuminemia, so the ACR will be between 3 and 30. Amyloidosis can also cause nephrotic syndrome. So in amyloidosis, you get deposits of amyloid in different organs around the body, and that can also happen in the kidney. And this fact is quite specific, but it can come up in exams. It's quite niche, but essentially the way that we would diagnose it is that on Congo red staining, you would see this apple green birefringent. So you can see right here that it glows this kind of like apple green color. Multiple myeloma, which is a bone marrow cancer in which there's an increased number of plasma cells or kind of antibody cells. It's a cancer of those cells, and it can also cause nephrotic syndrome. So the way it's implicated in the kidney is that it can cause tubular obstruction due to these deposits of the light chains of the plasma cells or the antibodies. And when these proteins leak into the urine, they obviously cause proteinuria, and these proteins are specifically known as Bence-Jones proteins. Okay, moving on to management now. So there are kind of several different branches to the management. Firstly, you want to reduce the edema, which can be done with IV loop diuretics such as furosemide, and also restricting their fluid and salt. And then, wait guys, just give me 1 second. Okay, yep. So a second thing you do is reduce the proteinuria. So you can give ACE inhibitors or ARBs, and this is what you'd give to all patients. You'd also want to reduce their risk of complications. So as I said before, there is a risk of thromboembolism, and so if they have nephrotic range proteinuria, you would anticoagulate them, and then if they develop thromboembolism, heparinize them. To reduce their cholesterol, you'd start them on a statin. You can give them spironolactone if they develop ascites, and then also manage their hypertension. And as I alluded to before about the immunosuppression and the recurrent infection, so anytime they develop an infection, you want to treat it promptly because their immune system is down, and make sure that they're vaccinated with the pneumococcal vaccine if they aren't already. Finally, you'd want to treat the underlying cause, whether that be an infection, malignancy, or a wider disease. If there are any causative drugs that you suspect might be causing the symptoms, stop them. And one thing to note is that certain primary causes have specific therapies. For example, as I mentioned, minimal change disease responds really well to prednisolone, so that would be the first line treatment. Okay, now moving on to nephritic syndrome. So with nephritic syndrome, it's characterized primarily by hematuria, and this is much more pronounced than the proteinuria. And patients will also have hypertension, oliguria, mild, i.e. non-nephrotic range proteinuria, as well as mild edema. So causes, and I've got sort of a diagram here which kind of goes through like the differences between nephritic and nephrotic syndrome. So as well as these symptoms, patients will also experience signs of uremia, so fatigue, nausea, pruritus. Causes of nephritic syndrome include IgA nephropathy, HSP, which is Henoch-Schönlein purpura, I think that's how you pronounce it, and post-streptococcal glomerulonephritis, Goodpasture's syndrome, small vessel vasculitis, rapidly progressive glomerulonephritis, and Alport syndrome. So I'm going to be going through all of these in a bit, but as I said before, don't get too bogged down by all of these. Make sure that you just focus on sort of the high-yield glomerulonephropathies. Okay, so in terms of IgA nephropathy, this is the most common form of glomerulonephritis in adults worldwide. And features include the fact that patients are often young males. Typically, they'll have macroscopic hematuria, and this is classically 2 to 4 days after an upper respiratory tract infection. And the reason why I've highlighted 2 to 4 days is because there's another another cause of nephritic syndrome known as post-streptococcal glomerulonephritis, which presents very similarly, but it actually occurs 2 to 4 weeks after an upper respiratory tract infection. And also these patients would have hypertension. In terms of investigations, first line is a urine dip, and then to diagnose, you do a renal biopsy in which there'd be increased amount of IgA and C3 deposition in the mesangium. To manage this disease, we're going to give them high-dose prednisolone, as this is going to delay them developing any renal impairment. The prognosis isn't great because a third of these patients will go on to develop end-stage renal failure. But that's kind of an overview of IgA nephropathy. Now we move on to Henoch-Schönlein purpura. So it's pretty much the same thing as an IgA nephropathy, but it's a systemic variant, and it's very common in childhood. Like, as in, it's not a common childhood condition, but as in, it's one of the most common vasculitides of childhood, and it's also typically seen after infections such as chickenpox, measles, and upper respiratory tract infection. Or something or another infection, and features include a palpable purpuric rash over the buttocks and extensor surfaces of the arms and legs, abdominal pain, kind of joint pain around the body, and also features of IgA nephropathy such as hematuria and renal failure. To manage it, we're going to be monitoring these patients. Like we will be monitoring their blood pressure as well as doing urinalysis, so that if they do develop IgA nephropathy, or if they do develop progressive renal impairment, we can deal with it ASAP. The condition itself is self-limiting and doesn't really require any kind of immediate treatment, as most cases will resolve on their own. But if they do develop blood pressure, like a high blood pressure, we can control it with ACE inhibitors. This is just an image of this rash that we're talking about. So it's palpable. So if you were to feel it, like the skin would be raised, and it's purpuric, meaning that it's kind of like distinct, like regions that aren't kind of merged into one. So for example, if it was petechia, I think petechia is kind of like all merged into one, but purpura is like not. Okay, so post-streptococcal glomerulonephritis, I was alluding to this before. So this is seen 2 to 4 weeks after an upper respiratory tract or a skin infection, and it commonly affects children. So in this situation, what happens is that the streptococcal antigen is deposited in the glomerulus, and that causes a host reaction and a subsequent immune complex formation. And so these deposits of these immune complexes are going to be seen in the renal biopsy. So in terms of investigations, you do a blood test, and if you see a raised anti-streptolysin O titer, then that confirms the diagnosis, and you'd also see a reduced C3 because this is being used up to form the immune complexes. Definitive diagnosis would be a renal biopsy, and you would see endothelial proliferation with neutrophils. You'd also see subepithelial humps, which are caused by these deposits of by these immune complex deposits. And this is a key, like a buzzword, that if you do immunofluorescence of the biopsy, it would appear like a starry sky, this kind of granular appearance. And in terms of management, it's actually just supportive, again, similar to HSP, because it's in most patients self-limiting and resolves on its own. Goodpasture syndrome or disease, otherwise known as anti-GBM disease. So this is another type of nephritic syndrome in which the patients develop autoantibodies to type 4 collagen. So this is a specific type of collagen that's found in the glomerular basement membrane as well as in the lungs, like in the alveoli. And it's composed of kind of these 3 helical chains, and these antibodies can develop to I'm assuming it's the alpha-3 chain, and as a result you have this immune response that's being triggered, and that causes inflammation, blood in the urine, things like that. Investigations will include a renal biopsy, and that will show linear IgG deposits along the GBM, linear because every single like there's obviously lots of collagen in the glomerular basement membrane, so all along it you'd have anti-GBM antibodies stuck there, and these kind of immune complex formations there. And then in the lungs, you'd have pulmonary hemorrhage, so that's one of the symptoms. And so you'd have a raised transfer factor. So transfer factor is actually the rate at which a gas diffuses from the alveoli into the blood. So it tells us kind of how good the oxygen transfer is, and it's useful because it indicates how much kind of functional capillary bed is in contact with the ventilated alveoli. So in pulmonary hemorrhage, you've got a lot of this blood that's being exposed to the lung tissue, and so the transfer factor would be raised. In terms of management, there are two steps. Firstly, you want to remove any of the circulating antibody there is, and this is through plasmapheresis, otherwise known as plasma exchange. And secondly, immunosuppression. So you want to basically dampen down the immune system to prevent it from producing further antibodies. And you can do this by giving them high-dose oral prednisolone or oral cyclophosphamide. Okay, moving on to small vessel vasculitis. So all of these conditions are quite rare, but I'm going to go through them because they are kind of causes of nephritic syndrome. So firstly, you have vasculitis in which there is which is characterized by P anchor, which is P anchor, and there are two types. So you've got eosinophilic granulomatosis with polyangiitis, otherwise known as EGPA, and this is characterized by adult onset asthma as well as eosinophilia, which is kind of indicated in the name itself. Or you can have microscopic polyangiitis, which is characterized by pulmonary hemorrhage. And then you can also have vasculitis that's characterized by an increase in C anchor or cytoplasmic anchor. And the condition which is related to this is granulomatosis with polyangiitis. This is also known as Wegener syndrome. So it can affect three different things. So firstly, the airways. So patients will experience chronic sinusitis, epistaxis, which is nosebleeds, saddle-shaped nose or nasal crusting. It can also affect the lungs. So when it affects the lungs, patients will have a cough, shortness of breath, they'll be coughing up blood, and also pleuritis. And then if it affects the kidneys, patients will experience hematuria, proteinuria, and a rapidly progressive glomerulonephritis. This is what I mean by the saddle-shaped nose deformity. So that's what you would see in Wegener syndrome. To manage it, you would do what you did similar to in good pastures. So you do plasmapheresis, get rid of all the plasma and replace it with fresh plasma, give them steroids, and then suppress their immune system. So rapidly progressive glomerulonephritis is where there's a rapid loss of renal function, and it's characterized by loads of these epithelial crescents that are found in the glomeruli when you biopsy it. This is one of the most aggressive types of glomerulonephritis, and it can lead to end-stage renal failure in a matter of days. And causes are what I've already covered. So actually, all the kind of nephritic syndrome causes I've covered can actually lead to rapidly progressive glomerulonephritis. So type 1 is caused by good pastures. Type 2 is a result of immune complex deposition, which is can be secondary to a number of things. So IgA nephropathy, HSP, post-streptococcal glomerulonephritis, lupus, etc. And in the histology, you'll see this granular immune complex deposition. So if you remember when I was talking about post-streptococcal glomerulonephritis, this like granular starry sky appearance. So that's what you would see. And then finally, small vessel vasculitis, which I was just talking about in the previous slide. On this biopsy, pretty much all of these, if the patient develops RPGN, then there'll definitely be these kind of epithelial crescents that are going to be present on the renal biopsy. Okay, so finally, I'm going to be going through Alport syndrome. So this is a inherited X-linked dominant condition in which you have a defect in type 4 collagen, and as a result, the glomerular basement membrane is abnormal. So if you see here, as I said, type collagen has 3 helical strands, and the mutation can occur anywhere along this, and it will lead to an abnormal membrane. So typically in exams, they'll describe a patient with Alport's that's given a renal transplant that's failing, and so what happens is that the Alport's patient is obviously not going to have any antibodies to their own glomerular basement membrane, which is abnormal. But when they're given a renal transplant, that's going to have normal type 4 collagen. And so the body is going to recognize that as something foreign, something abnormal, and then develop antibodies against it. And so you'll kind of see a good pastures-like syndrome. So I think that's a good kind of like fact to remember if it does come up in exams. In terms of features, so it presents in childhood, presents with microscopic hematuria, so you'll see it in like a urine dip, but there won't be any kind of frank blood in the urine. And it can be implicated in the eyes, causing anterior lenticonus. So what that is this abnormal conical protrusion and bulge of the lens, which happens because the lens capsule, it thins out. And then these patients may also have something called retinitis pigmentosa, which is black pigmentation and degeneration of the retina, and currently there's no cure for that. In the glomerulus, they'll have progressive hematuria and proteinuria, and it also affects the cochlea, so they'll have bilateral sensory neural hearing loss. On renal biopsy, you have this classic basket weave appearance due to thinning of the glomerular basement membrane. And in terms of management, the only definitive cure is transplantation, but we can symptom manage using ACE inhibitors and ARBs. And I've just included this diagram because it kind of contains sort of like information about the pathophysiology, the features, management, etc. So that'd be good, kind of useful to go through in your own time. So there are a number of systemic diseases which can have renal manifestations, such as diabetic nephropathy, amyloidosis, multiple myeloma, which I've kind of talked about. But there's a number of other conditions that can also cause renal problems, and these include HUS and TTP. So HUS, otherwise known as hemolytic uremic syndrome, is a type of hemorrhagic colitis which is caused by E. coli. So there's a specific strain of E. coli known as 015H7, which produces this Shiga toxin, and it leads to a triad of microangiopathic hemolytic anemia, aka MAHA, thrombocytopenia, and AKI. And in this AKI, you'll see hematuria and proteinuria. So that's kind of like as in the E. coli, it's basically causing some sort of renal problem. And then you have TTP, or thrombotic thrombocytopenic purpura, and this is basically when there's either a congenital deficiency or of the Adams TE13 protease, or if the body kind of produces antibodies to this protein. So the function of this protein is that it basically there's something called von Willebrand factor, which is involved in it's basically involved in platelet aggregation, and Adams T3 protein, it basically cuts off this von Willebrand factor, like kind of cleaves it off to make sure that like basically too much clots don't form, and it's characterized by a pentad of the HUS triad, so all of these three things, as well as neurological symptoms and fever. So neurological symptoms include headaches, seizures, palsies, confusion, and coma. And that's kind of like a summary of TTP. So I'll quickly go through the quiz. There are several questions. So the first one is that you have a 29-year-old Caucasian man, and he comes to the GP with hematuria and loin pain, and he's also been suffering from recurrent UTIs over the past few years, but they've always resolved with antibiotics. He mentions that his dad had some kind of kidney issue and also hypertension, and passed away from a stroke 4 years ago. So the question's asking that what other complication is he most at risk of? So I'm just going to give you guys a couple of minutes to read through this and then suggest an answer. Does anyone know what it could be?
I'm going to go with sepsis.
Okay, that's a good one. Why do you think it's sepsis?
I'm thinking he's... Is someone else speaking? Oh, I'm thinking he's like progressed to pyelonephritis.
Mm-hmm.
I've crossed out A, D, and E, so just between B and C, I thought more likely to be sepsis, some kind of urine infection from the spread from the pyelonephritis.
Okay, fine. So let's go through this question and try to understand what the answer is. So the answer is actually subarachnoid hemorrhage. So based on the stem, we can infer that the patient has ADPKD, or autosomal dominant and polycystic kidney disease, because he's quite young and he keeps having these kidney problems. And his dad also had the same thing. So we can see there's kind of this inheritance happening. And he passed away from a stroke. So we know that in ADPKD, patients, it predisposes patients to developing berry aneurysms, which can then burst and lead to a hemorrhagic stroke, which is what we can assume the father passed away from. So to rule out the other ones, so cataracts, you're right, there's no visual issues in this condition, and so we can rule that out. Hemolytic anemia, this is found in HUS and TTP, so again, it's not relevant to this question. ADPKD isn't caused by an infection, so it wouldn't be sepsis. But it was a good suggestion. And then cirrhosis, it's not cirrhosis because although in ADPKD you can see liver cysts, it doesn't actually cause cirrhosis. Okay, let's go to the next one. So SBA2, a 32-year-old man presents with hematuria, and also that it's becoming frothy, so we're thinking proteinuria. And he's got a past medical history of bilateral sensory neural hearing loss, and is currently under ophthalmology for visual issues. So with this patient, what's the most important immediate management? I'm going to give you guys some time to think, and then feel free to shout out the answer. Does anyone want to give a guess? Okay, that's fine. So let's go through it. The answer is actually an ACE inhibitor. So this patient has Alport syndrome, which is indicated by the fact that he has bilateral sensory neural hearing loss. Remember, I said that in Alports, different kind of systems are affected, including the eyes and the cochlea. And he's experiencing hematuria and proteinuria. So in order to deal with that, in order to deal with those symptoms, we're gonna give him an ACE inhibitor, which is a vasodilator. So it's gonna reduce the hypertension and kind of hopefully improve his symptoms. We wouldn't give him warfarin because in Alports there's no effect. It has no effect on coagulation. Like it's not gonna put him in a hypocoagulable state. In the future, he might need a transplant, but that's not something you're going to consider immediately. Prednisolone, which is a steroid, that's used in glomerulonephritis. This isn't glomerulonephritis. It's an inherited condition, and this one we can also rule out because he doesn't have pain and he's not dehydrated, so he wouldn't need fluids. Okay, next one. So a 72-year-old man comes to A&E with anuria. He can't urinate, and he's admitted, and they note that he's got stage 2 AKI because his urine output's been less than 0.5 milliliters per kilogram per hour for over 12 hours. However, he's not hypertensive at all during this time. So they send out a blood test to measure the full blood count, urea, electrolytes, and LFTs, but no cause can be identified. So in this case, what's the most important investigation that you're going to order next?
C.
Yes, very good. Well done. Answer is C. So basically, in all patients that have an AKI, we don't know the underlying cause. We're always going to order an ultrasound. The chest X-ray is useful if there was like pulmonary edema we were suspecting, but he's not short of breath here. An abdominal X-ray is kind of low-key useful if you suspect renal stones, but he doesn't have any loin pain. Again, this isn't really sort of a second thing that you would do, and this as well, like it's useful in renal vessel occlusion, but he's remained normotensive this entire time, so we wouldn't do that. Okay, so the fourth one, A 32-year-old female with membranous nephropathy presents to A&E with sudden onset left-sided flank pain and visible hematuria. Investigations are carried out and the results are shown here. So what is the most likely cause of her symptoms based on this history?
Is it pyelonephritis?
Okay, that's a good kind of differential to consider because of the left-sided flank pain and the hematuria. So that's definitely something we can consider. But if we're going to think about the most likely cause of her symptoms, so we know that she's got pre-existing membranous nephropathy. So in these patients, they basically have an increased risk of developing renal vein thrombosis. So do you remember right at the beginning when I was talking about complications of nephrotic syndrome, I said that there's leakage of anti-clotting factors such as antithrombin 3. And so this means that these patients are more at a risk of thrombosis. And thrombosis is a tetrad of loin pain, which she's having. She's also having hematuria. She's also got an AKI because of, well, it's likely AKI because of the raised urea and creatinine. And then also these patients, if they have renal vein thrombosis, will have a raised LDH, which we can't see at the moment, but it would probably be raised. She's not pregnant, so we can rule out the ectopic pregnancy. And in terms of there's no nitrites, no bacteria, so it wouldn't be, yeah. Does that make sense? So in terms of last question, let's just quickly go through it. Which of the following is a cause of rapidly progressive glomerulonephritis? So do you guys remember how a couple of slides ago I was talking, it's just like one slide on RPGN and how all the different glomerulonephritides can actually lead to or turn into a rapidly progressive disease. So which one of these situations would be a cause of RPGN?
I have no idea, but I'll guess C.
Okay, so let's go through it. So for the first one, if a patient has antibodies against podocytes, and that's membranous nephropathy, if they have IgA deposition in the mesangial cells, then it's IgA nephropathy. If they have streptococcal deposition of the streptococcal antigen, it's post-streptococcal, and if it's an X-linked defect in the type 4 collagen synthesis, that's Alport's. But in when there's antibodies against the glomerular basement membrane, then you have type 1 RPGN. I think this question, there might be something wrong with it actually, because we know that IgA nephropathy and post-streptococcal glomerulonephritis can also cause RPGN, type 2 RPGN. So I'll have a look at that. We can definitely cross out this one though, because it's an inherited disorder. Okay, guys, so that was the end of the presentation. I hope that helped. Do you guys have any questions before we end the recording? Okay, I'm assuming that's a no. So yeah, thanks again for coming. I hope that was useful, and hopefully we'll see you soon.